Good evening, California. Welcome to our virtual town hall on preventing the next pandemic. I'd like to take a moment to thank our three panelists, Dr. Higgs, Dr. Baines, and Dr. Lau, for being here today. It has been over a year since the beginning of the COVID-19 pandemic. The loss has been significant. The virus has claimed the lives of millions, including 57,000 people in the state of California. It has shattered businesses. It has disrupted the education of our children and their well-being. Food insecurity and poverty have increased, and people are hurting, and we must do everything we can to prevent this from ever happening again. This means that we must do better, but we must do better by understanding the origins of such diseases and be better prepared for it. The Center for Disease and Control estimates that 3 out of 4 emerging infectious diseases in people come from animals. And since 1980, they're becoming more frequent and deadlier. Dr. Stephen Higgs, our first panelist, is the director of the National Biosecurity Research Institute and Associate Vice President of Research at Kansas State University. He recently gave testimony to the U.S. Senate at its hearing on agricultural research and securing the United States food supply. Our second panelist, Dr. Jasmine Baines, is a physician in Kern County. Dr. Baines goes above and beyond for her patients and has worked tirelessly to ensure that the standard of care they receive is not negatively impacted by how far they live from healthcare facilities. As a physician, she has been working on the front lines of this pandemic. Dr. Lau, our final panelist, is a professor of microbiology at CSU Bakersfield. Dr. Lau is a microbial ecologist interested in interactions between microbes and symbiosis between microorganisms, invertebrates, and vertebrates. She has conducted extensive research on valley fever. So Dr. Higgs, I first came across your work during the U.S. Senate Agricultural Committee hearing. Can you share with Californians what your testimony was about and a little bit about your work at Kansas State University?
Well, thank you, Senator. It's such a privilege to be on your call today. Most unexpected to be talking to Californians. So my testimony to the Senate Ag Committee was concerning the importance of research in terms of preparedness for the types of pandemics that we've been seeing. And I have a few slides. I didn't know whether I was supposed to have slides, and I probably have too many now, but let me share my screen, because the two questions you posed to me were, what is needed to prevent the next pandemic, and how prepared are we? So let me show you this one slide right from the beginning, and it's can you see that okay?
Yes.
Right. So what is lacking? So this is the bipartisan Blue Ribbon Panel on Biodefense. It's now the Bipartisan Commission on Biodefense. And they've reviewed our preparedness in the United States, including the 2004 Presidential Directive, which is securing our Agriculture and Food Act. And their conclusion was their review was very thorough. And what is lacking? No leadership, no strategic plan, and no budget. That is pretty damning when you think about the potential threats that are coming out from the wild quite often. And as you mentioned, about 70% of new diseases are so-called zoonotic, coming from animals. And we really just are not prepared. As you've seen in California, and we've seen in the rest of the United States, we've had West Nile, we've had chikungunya, we've had Zika. We never seem to be prepared enough. We often know what is on the horizon, but we seem to have blinkered visions and not prepare for it. And the same for SARS-CoV-2 virus, which we're all facing now. We knew some time before it got here that it was out there and likely to be heading our way. So we need structure, we need preparedness, and I know you have introduced an act to try and get preparedness and funding for the institute there in Fresno, which would be just wonderful. Everything would help us to do that. if you'd like me to talk about my institute, I'm very happy to do that. And I can tell you a little bit about what I do and where I work. I'm trying to do this at the moment and advance, and there we go. So we're at Kansas State University. We've been operating since 2007. It's a rather expensive facility. It costs about $55 million to build and about $5 million a year to operate. But it is quite unique. There's no other facility quite like this in the world. What we work on are diseases of livestock, including zoonotic diseases that infect people, diseases of plants, and foodborne pathogens as well. So this is just an overview of the lab, and we have a red barrier around here because we are what we call high containment. We mainly at what they call biosafety level 3. That's one level down from Ebola, if you like. And we work in that safe, secure envelope pretty much every day. We've hardly closed down. We've never really closed down since COVID pandemic started. We just restructured some of our research, as I will talk about. So we've got a food wing, a plant wing, and then this is the livestock area. We've been working on SARS-CoV. We've been working on several pathogens which are very significant potential threats to the United States. We're actually the first and only institute to work on some of these pathogens outside of American federal facilities. Like I say, I will go through this quickly. I have about 35 people working for me, and we have about 25 researchers with teams that amass to about 150 people coming through those doors on a regular basis. We do take safety and security very seriously, as you would imagine. All of our employees are very thoroughly background checked and fingerprinted because of the nature of what we do. We've got this National Agricultural Biosecurity Center based here at the BRI, who are working with Homeland Security and FEMA and other agencies to prepare us for things like SARS-CoV-2 or animal diseases such as African swine fever. So they are working on a program on animal disease response training and preparedness for the United States. Training is very important because of the nature of the pathogens that we work with. Some of them are highly infectious and often lethal. So we have a very rigorous training program, which would have to be part of your program if you succeed in getting that funded, which I hope you do, obviously. We have biosecurity graduate certificate programs. We have annual programs. This is on transboundary animal diseases. I've been reviewing potential students for this today. This will be held where we have 10 or 12 students coming and learning about the pathogens that might affect our agriculture. And in these circumstances, knowledge really is power. You need to understand these pathogens in order to detect them and in order to respond to them appropriately. And then obviously you're in a part of the United States that is extremely rich in terms of agriculture on plants, vegetables, fruit, and so forth. And we have routinely every year a plant biosecurity course where we have 20 students from sometimes a dozen different countries. In terms of the research that we do, we've worked on about 20 different pathogens. The ones in red are focus areas for a lab that is being built next to us, National Agricultural Biosecurity, NBAF, and National Bioagro Defense Center. And this is our plant research area. We're working on a thing called wheat blast that could essentially destroy all of the wheat in the US if it's spread here. The only way you control it is by burning. This is the food wing. You are obviously concerned and have asked me about the impact of COVID on meat processing plants. Believe it or not, in high containment, we actually have a facility with real equipment. This is a carcass washer that would be found in a meat processing plant. This is unusual to have into this sort of thing. And this chamber here, what we can do is we can precision contaminate carcasses and and then evaluate methods that have been designed to decontaminate them. So they go into this chamber and get contaminated, and then go through the decontamination carcass washer to see if what we're using works and how to improve upon it. We're one of very few facilities that can work with large animals. We work with a number of different livestock species. They're very well cared for while they're here. It's very rigorous review. But we're doing research on animals to save the lives of animals, to save the lives of people, and to help agriculture. I know in one of your statements you referred to the avian influenza epidemic, which in just a year cost $3.3 billion to the US. Researchers here at the BRI developed vaccines for these influenza strains at that time. We're working on classical swine fever. We've got researchers who have developed a brand new vaccine for that, even a plant-based vaccine so that you can feed pigs and protect them. This is something that kills about 90% of the pigs it infects. You may have heard, or your constituencies may have heard of African swine fever, which has been spreading around Europe, Eastern Europe, and Asia at an absolutely alarming rate. It kills 90% of the pigs. China, just on its own, has probably lost 200 million pigs to this. If it ever were to get into the United States, not only would it destroy our industry, but it would also prevent exports instantaneously if this is introduced here. And the studies that we have been doing have included pathway analysis, how this virus could get into the United States, and then how you could detect it. This is a pen check diagnostic that Dr. Richter's produced. And then we work on mosquito-borne diseases, things like chikungunya, yellow fever, Zika, and so forth. And then last year, we had just started up a lot of animal research, and of course, SARS-CoV-2 was introduced into the United States. The beauty of being a university is that we can be quite nimble, and what we did very quickly was reorganize our research platform as soon as we could get the virus and start research on SARS-CoV. The administration here at the university were very supportive of this, thank goodness. This is just a picture of the work that we did. We just started PRRS and African swine fever research, and then in April, we started SARS-CoV research. And you can see these blocks in red were studies that had not been planned or thought of in February or March, but which we were able to very quickly initiate. We worked on mosquitoes. We were very happy to prove that mosquitoes were not susceptible to this virus and could not spread it. Imagine how much more of a problem SARS would be if it were transmitted by mosquitoes. It was it was actually translated into 18 different languages. That went around the world as good news, and there wasn't much good news at that time. And then we've got research groups working on swine to see if pigs were infectable. There'd obviously been discussion of the threat of SARS-CoV-2 infecting domestic species, particularly companion animals. So this group did work on swine, cats, and hamsters as models. Incidentally, they did a study that's just been published on how long the virus can survive on all sorts of different materials. And that is relevant to the slaughterhouses and so forth. I won't bother you with this. It's freely available. And then this project was actually funded. This is $1 million project from USDA, and then the state of Kansas donated $330,000. This is looking at how long does the virus stay on materials which are actually in slaughterhouses and meat processing plants. We really don't know why there was such an incredible predisposition, if you like, of workers to this virus. So that work is just starting at the moment. They're starting those studies now. And that is it. That's a very brief overview of the facility. We have a website. I'd be very happy to answer questions. I hope I've covered what you wanted, but I will end there.
Thank you, Dr. Higgs. I know there's been, we talked quite a bit about animals and the importance of animals in regards to this pandemic. And I know that today the World Health Organization, the organization that has been tasked with investigating the origins of COVID-19, and we're expecting their findings to come out soon. But reports, media reports today throughout the day have been claiming that this report is more than likely going to point to the fact that COVID-19 jumped from an animal to a human, and that being extremely important as being something that could continue to happen more and more. And it seems like it's not just a threat to animals are food. It's also a threat to our health, human health, right? And I know that Dr. Baines has been at the forefront of this pandemic, working to treat patients and save lives. And so I just want to hand it over to Dr. Baines and see if we can just get a little bit of her perspective in fighting the COVID-19 pandemic and what more we need to do to make sure that we don't ever let this happen again.
Thank you, Senator.
Thank you. Dr. Baines?
Okay, can you guys hear me now?
Yes.
Okay, I apologize. So I just want to say good afternoon, everyone. Thank you, Dr. Higgs, for that exceptional presentation. Thank you, Senator Hurtado, for putting great people together to discuss something that's really important. And then, I mean, it's been an exceptional year, and I think discussion is very important. So thank you for bringing that to the table. Preparing for the next pandemic is really important, but at the same time, strengthening our response and preparing our defense is equally important in that preparation of a pandemic as well. We got to be ready for what's headed our way. So I'm Jasmeet Kaur Baines. I am a board certified family medicine physician with the fellowship in primary care psychiatry. I am currently physician and medical director at Dignity Health Foundations in Bakersfield, California, and medical director of Bakersfield Recovery Services. I also am a governor appointed commissioner as chair of the California Healthcare Workforce Policy Commission with OSHPD, and also I'm a member of the California Developmental Services Task Force with the DDS, and a volunteer physician with the Emergency Medical Services Authority, part of the Central Valley Medical Unit, also an avid researcher and global health outreach, done lots of projects out in Ecuador, Honduras, Nicaragua, Ghana, and India. So when it comes to strengthening our response, something I've been advocating for a very long time, even before the pandemic, is increasing our healthcare workforce. Our healthcare workforce was already challenged before the pandemic, and it was kind of slingshotted to the front and revealed that this was already a problem in America. We need more nurse practitioners, we need more physician assistants, we need more MDs, we need more DOs, we need more nurses, we need more pharmacists, we need more therapists, we need more support staff. Healthcare workforce has been challenged for very many years. If we want to prepare a good defense for a pandemic, we've got to make sure that we have people that can support that defense. And that's been something that we've been lacking for many years. Let's look at the root of a COVID-19 pandemic. The majority of patients that were affected by COVID-19 weren't in the hospital. They were being cared for diligently by their primary care, ambulatory care physicians, nurse practitioners, RNs, PAs. All of your ambulatory care settings were the ones calling your patients, making sure that they were okay, making sure they're getting the proper surveillance and medications. That's your real key defense to a pandemic. Investing in your primary care infrastructure. Primary care prevention is going to be the mainstay of preparing us for a future pandemic. Increasing funding and research in effective treatment options is really important. Effective communication. I think communication was very poor during this pandemic. It wasn't available in different languages in the beginning. People didn't understand what was going on. Making sure that your patients understand what is going on is what's going to make sure that people protect themselves the best. And then prioritizing and protecting our vulnerable populations and identifying our vulnerable populations. I don't think very many people understood what a vulnerable population meant before the pandemic. Our elderly, our population with developmental intellectual disabilities, who studies show are at 7-fold increase of mortality from a COVID-19 infection, are immunocompromised. These populations need to be identified and they need to be supported in every way possible. Treatment options for COVID-19. So why did we struggle to provide effective treatment options in a timely manner? Treatment options were available. They were available back in November, but they weren't being utilized in your outpatient settings because most of them were requiring infusion centers that can infuse them. And the only place that could do that was through an ER or an emergency room in hospital. They were only available in the hospitals or ERs, further increasing emergency room visits that could have been addressed in an outpatient setting. I worked with the Emergency Medical Services Authority to start opening up infusion centers. I even worked with my local hospital to create that avenue for an outpatient flow of patients to get treatment that was available. Your antiviral, remdesivir, was a treatment option for COVID-19. That's only available in the hospitals because it was an infusion. Now we're working on getting an oral form of that, and that's going to help decrease hospitalization visits because you had numerous patients that were in the hospital just trying to get their 5-day treatment course of remdesivir. Your monoclonal antibody treatments, which is an infusion that you need to get right away after coming positive for a COVID-19 infection, and studies have shown that it decreases hospitalization rates. Outpatient oxygen monitoring, home health therapy programs. All of these avenues of outpatient treatment was struggling, and having this available for patients in a timely manner could have helped avert a lot of deaths and save a lot of healthcare costs as well. Let's talk about rural healthcare. The first few months of the pandemic, last year I was in a rural federally qualified health center in Taft, California. And these are what I experienced. I experienced all of a sudden, all of my substance abuse treatment patients decreased. They jumped out of substance abuse treatment. All of a sudden, those same patients were coming back with intravenous induced abscesses for treatment for their abscesses, increase in domestic abuse, miscarriages, intoxication. A lot of this came from ineffective communication that we didn't provide for patients. Increase in depression, anxiety, past trauma, underlying mental health disorders were highlighted during this pandemic. Ineffective communication for non-English speaking populations, people losing their jobs. It directly correlates to people losing health insurance. How is it that we were in a pandemic and people were losing their jobs and losing their health insurance, and this was our response for a COVID-19 pandemic? And then decreased healthcare visits, people being afraid to come to the doctor versus people being extra alert and coming into the ED. You saw a flow of patients leaving your outpatient practice and going to the emergency room because there were no treatment options that were available in the beginning. And then I really fear about reintegration of society post-isolation. Mental health backlashes of social isolation is very real. And you can see that in solitary confinement amongst prisoners. You will see a lot of the mental health backlash being presented by increased drug activity. You had increased fentanyl-laced drugs that led to increased overdoses in our society. increased anxiety, stress, hopelessness, anger, panic attacks, worsening pre-existing mental health issues, problems with attention, concentration, paranoia, poor impulse control, social withdrawal, and self-harm. I see this on a daily basis in my clinic. Just today, I had 3 of those listed in my clinic today. This is something that we are dealing with across the boards in all healthcare. And then I wanted to throw in a couple of case presentations. One was a 72-year-old female with past history of interstitial lung disease and hypertension, positive for SARS-CoV-2 on January 22nd. This was part of the outpatient monoclonal antibody therapy program that we set up at Bakersfield Memorial Hospital. This patient was infused on the 25th with 700 milligrams of the monoclonal antibody therapy, which was for COVID-19 specifically. Patient did well. I telehealthed her 24 hours post. She still was doing well, no concerns. Followed up with her a week after infusion, no concerns, and still remains asymptomatic to this day. Her husband, however, who also tested positive before her, did not get the infusion, stayed in the hospital for 2 weeks, required oxygen and plasma donation, and was eventually weaned off of oxygen, transferred to a skilled nursing facility. And then the other side, this was something that happened early in the pandemic last year. One of my 27-year-old female with interuterine pregnancy at 10 weeks, seeking treatment for pregnancy and substance abuse treatment. So I started her on Suboxone therapy to treat her opioid abuse and weekly appointments, in addition to doing her prenatal visits. Patient failed to come to follow up with me a week later. 3 days later, she returns and she tells me that she was assaulted by her boyfriend. She went to the emergency room for a threatened miscarriage, was in pain, and was restarted on her opioid pain medication. And then she miscarried 3 days later. So overall, I guess what I'm trying to create a picture of is, yes, we can increase treatment options. And that's an important part of strengthening our defense. But increasing healthcare, supporting our primary care healthcare infrastructure is essential on decreasing healthcare disparities. And that's something I've advocated for a very long time, and I will continue to do so. You know, every patient has a unique situation, a unique experience, and a lot of those stories have not come out. And they're, especially when it comes to the mental health aspect, especially when it comes to the stories of people that have died, have been afflicted with COVID-19, and then not even to talk about the long-term complications of COVID-19. We're just discovering what the long-term complications are when it comes to cardiomyopathy, when it comes to long-term lung damage, when it comes to strokes. We're still figuring that out. So there's a lot of work to be done, and we need to make sure that we invest in it wisely. So thank you again, Senator Hurtado, for that.
Thank you, Dr. Baines, for that presentation. And we know that here in the Central Valley, we have limited access to healthcare for just historically. And we appreciate your work in reaching every patient possible in our rural communities. And we know that also by COVID-19, rural communities have been the hardest hit. So we appreciate the work that you do, and want to move on over to Dr. Lauer, who has done a lot of work and research around valley fever, something that we know unfortunately, we know all too much about here in the Central Valley. And so, Dr. Lauer, I want to just hand it over to you to speak a little bit about some of the work that you've done and how we can prevent this next pandemic.
Okay, good. So thanks for inviting me to this nice round, and I enjoyed the presentation so far. I learned some things, I made some notes, for later discussions maybe. And let me share my slides. Just a moment. Okay, can everybody see them?
Yes.
Okay, good. So let's make it big. Okay, so this is my entry slide. So just the title, Preventing the Next Pandemic. And I always make my presentations colorful so you can see that I'm a teacher. I try to get the attention of my student audience, and I don't know who's listening today beside of our panelists. You know, there might be students watching, I don't know. But I put this first slide here before I introduce myself just to show you that we are bombarded with information. You know, there's social media, there are journals, there are peer-reviewed journals that we are supposed to trust, but there's also a lot of sensationalism out there, and we are often confused about what data we actually can trust. You know, when we look at the Time magazine, a well-respected journal, warning we are not ready for the next pandemic, you know, this is like creating a panic among the population. But there's other nicely composed material that might be useful when we want to work on preventing the next pandemic. Yeah. Okay, so let me introduce myself first a little bit. So I'm originally from Germany, so I'm also observing what's going on in Germany with the pandemic, and I can compare what in my opinion is being done right and what is not so good. And there are big differences, but this goes beyond our talk today. So I'm faculty at CSU Bakersfield since fall 2007. So I'm predominantly a teacher. So these are some classes that I teach. So I'm also a researcher together with undergraduate and graduate students. And my main research topic is valley fever. I've done a couple other things in the past, all like environmental microbiology. So I'm not a medical doctor. I'm actually an environmental microbiologist or microbial ecologist. So for valley fever, I try more to investigate why the pathogen is present in certain areas. You know, what are the environmental parameters? What is kind of triggering that it is in the air? Why is it in some areas more than in others? How is the climate contributing to this? And we also have a valley fever study group meeting every year where all the researchers come together to share what we have learned, and that these are physicians, these are immunologists, these are field people like me, these are teachers, and it's also open for students. Yeah. Okay, I also do a little bit of outreach to the community, and one really great project that I'm launching this April actually is a citizen science project together with teachers here in Bakersfield, involving students and teachers to sample dust throughout the years to investigate if the pathogen is in the dust. So we have already kind of a map where it's in the soil, but we often hear the criticism that, okay, we know it's in the soil, but to prove that it is dangerous, you have to prove that it is in the dust and people inhale it. Yeah, so this is why we want to put an emphasis. And the second is also to educate more young people and teachers, and with them probably their families, about the dangers of valley fever that has like an epidemic character, not a pandemic because it's not contagious, but it is definitely an epidemic. If you want to learn more about my publications, everything, I have a ResearchGate page and a LinkedIn page, but this is going beyond everything today. So how can we actually prevent the next pandemic? And we already learned from Dr. Baines and Dr. Higgs a lot about how to approach that. Yeah, so do your homework, right? So you have to learn from pandemics. And when you look back, you know, it's not that we have not learned a lot already through pandemics from those pathogens listed here. We have actually learned a lot, but often what was a hindering factor is money. You know, how can we, let's say, justify that we have, let's say, ordered 100 extra respirators, and then later it turned out that the pathogen that was considered so dangerous magically disappeared. And then we will be kind of accused of having wasted tax dollars. You know, this is often a hindering argument. You know, we scientists, of course, we want to kind of promote this has to be improved and this has to be improved, but it also has to be practical, of practical use. You know, you have to justify that this is happening. How are you sure that you really need that? And how do you sell that to the public? You know, this is, and to your fellow politicians and the community, the boards of whatever. Yeah, so it's not that easy. Yeah, so that is the second thing that people have to work on. So, and when we're learning from pandemics, you know, we scientists, we learn that we are only trusting peer-reviewed data. But we often realize when we actually look at the data that the data is not that good. Yeah, and or how the data is presented is misleading. And I have a slide later that shows you what I mean. And then the high-risk pathogens that cause pandemics in the last 10 years are those that are listed here. But then we should also not forget that we have ongoing pandemics forever and ever. And we are not talking about this at all. HIV, tuberculosis, especially here in the Central Valley. Yeah, and when we have a lot of people who suffer from other issues, also including valley fever, the bad air and everything, that makes us more vulnerable for the next pandemic because our immune system, our general health is kind of compromised. So when you think about long-term strategies, how to make us less vulnerable, the plan should also include how to make us more healthy. Yeah, so these are long-term plans. And I know that in politics, it's often very fancy and fashionable to jump on the short-term solutions and maybe keep the long-term solutions for the next person, right? But you know, if you really want to make big changes, you have to consider long-term changes are important. Yeah, long-term changes. Yeah, and to study pathogens, of course, you need to know what they are and how they are transmitted. So for those that are listed in the previous slide, this is something similar that Dr. Higgs already showed, so I don't want to be very repetitive. The point of this slide is just to show you that most of those threats are viruses and very few are bacteria or parasites. So the next pandemic that might hit humans, you know, there are also other pandemics that can hit our agriculture, like Dr. Higgs said. But what will hit humans and our livestock, that is probably a virus. Yeah. And then the most dangerous virus that is the most contagious is the one that is airborne via aerosols. Yeah. And then also important is also if there are vectors involved. Vector is a mosquito or an arthropod that bites you and transmits a virus. So with COVID-19, there is no vector involved. But we have, for example, West Nile that has a vector. Yeah. And most of those are viruses. And cholera and plague, okay, we have some outbreaks. There's actually an ongoing cholera epidemic, but it's not really affecting the United States. It's mostly after hurricanes and problems with being very sanitary. So feces are floating around after hurricanes or flooding, you know, that increases cholera. And the plague, we have occasionally a few people in the Central Valley that contract the plague, but we have an antibiotic that works also against cholera. We have actually really good treatment. And for these other viral pathogens over here, we have a little bit of a treatment, but it's not that this is a cure. You know, if you contract any of those diseases, if you really want to get cured, your immune system have to give this kind of pathogen the final blow, because all these treatments are only, let's say, inhibitive, yeah, or they enhance your immune response, but they are not kind of eliminating the pathogen from your body. Your immune system has to do that. Yeah, and that's why I'm saying also to my students all the time, the best way to protect yourself against all kinds of infectious diseases is to try to stay as healthy as you can with healthy food, with exercise, not too much stress, and all these things that we already learned a long time ago, right? So it's nothing new, but we have to just also rely on those things and not just wait that somebody develops the next vaccine, which might or might not happen. Yeah. Okay. And then with climate change, we might have a change. We might actually have some other kind of pathogens coming closer. And they might actually come via vectors, because Zika and chikungunya, what Dr. Higgs also mentioned, and what I'm sure Dr. Baines know about, they are transported by mosquitoes. And we know that mosquitoes are here in the Central Valley, especially the Aedes aegypti, the little ankle biter that was there last year. I think everybody remembers these tiny little mosquitoes that are also day active. Yeah, so they are a problem, but it's also that there are some Culex mosquitoes that are carrying some dangerous pathogens. Okay, so not much more about this. Okay, so how do we get data? You know, this is something that I always show my students, and it's just one example of a public database where you can quickly get an idea about what is going on in the world regarding outbreaks. Yeah. So this is actually originally from the Boston Children's Hospital. It originated in 2006, and they're taking in information from all kinds of sources. If you want to see a list of sources who provide information, it's peer-reviewed papers, it is case studies, it is an alert in the news, you know, a lot of different sources to provide this map. And then you can click on these kind of dots, and depending on the severity, they have different colors and sizes. So I looked at it. like 2 days ago, and I saw that there are 69 alerts for avian influenza in the past month. And when you look at it, oh yeah, Asia, Europe, and luckily in the United States, only one. Yeah. But look, this is the first step to be prepared, to look what's going on. See, okay, maybe there's something coming and we want to be prepared. Yeah. So avian influenza is related to the flu that humans can get. You know, when you all have heard about the Spanish flu, you know, that flu that killed, people say, about 50 million humans. That's an estimate. That H1N1 flu virus was a mix of an avian flu and a human flu. So these different flu viruses, the swine flu, the avian flu, the human flu, they can all mingle and exchange their genome, because if you are a virologist, you know that they have segmented genomes. And if they co-infect a person, they can accidentally mix everything. And out of a co-infection with one swine flu and one avian flu, there could be like 5 new versions of something originating. Yeah, so this is a really nice website where everybody can get information. So you don't need to wait until Johns Hopkins University has found that out, or our Kern County Health Department. You can look at it every day. Yeah, so I look at this with my students actually every year. And you can also look what's going on with Ebola. There's actually right now in Oregon, there are 20 people under watch because they returned from Liberia, where there were 27 people who died of Ebola. You know, they're now under watch or quarantine in Oregon. You know, all these things you can get scared of, or you can just see, okay, this is just some start about to get informed. So this is data that is a mix of sources, and there might be some sources that are not as trustworthy as others, but it's definitely a start. Yeah, and then have a look at this. You know, we are seeing all these pictures. So let's, for example, have a look at this. Yeah, this is from the Science magazine. You know that's a trustworthy source, the Science magazine. So they actually compared excess death per million. So excess death, that means how many more people died during that time that is here, more than normal. So usually there's a range about so and so many people die every month. There's a normal threshold. Humans die, animals die. We actually die at some point. That's also something that humans sometimes forget, that we have to die at some point, right? So this is how many more people died, unexpected. And probably because the only pandemic that was going on was COVID. So they compared England, Sweden, Norway, Germany, and Denmark. And there are also graphs like this for the United States. I only pointed that out because Europe has so many different countries that we can easily make these graphs. And you can see that England and Wales had a huge spike. And Sweden, that actually had that more relaxed policy with no lockdowns, or with just educating the people and just voluntarily means and measures. So Sweden actually did not as bad as we would expect. Actually, England and Wales did much worse. Yeah, and then the other countries did better. But then, you know, now we are so much smarter. So now we already have next year, March, right? So we now know that there are all these different mutants. At that time, when this graph was being made, we didn't know that there was probably in the future a dangerous South African mutant, there was a dangerous Brazilian mutant, there was this dangerous mutant in the United Kingdom, the B117, and we only know because we started sequencing all these kind of coronaviruses that killed people, but we didn't start sequencing a lot of them here. So maybe there was already a more dangerous mutant in England, and we can't just compare the data because there are different mutants in the different countries. Yeah, so we don't know. We have to go back and look at these blood samples that are probably still sitting in some freezers, and we can probably get this data in the future. But you know, this is what I mean. The graph looks like, oh, England and Wales, they didn't do a good job with everything, but maybe there's more to the story. Yeah, always look at these graphs with a critical mind. Yeah, and then when you look at this is like the pandemic's disproportionate toll on the elderly. We heard that before. Yeah, COVID death per population. So we have like very few elderly in our overall population. And this is from the website Statista. This is also open to the public. So this is the United States. Yeah, so it's from the US Census Bureau. So we have very few elderly and a lot more younger folks. But as we heard before, it's mostly the elderly population that is vulnerable. And of course, because they have underlying conditions, they're already sick. Yeah, they are very vulnerable. Their immune system is not working that great. Yeah, so they are anyway at risk. They're at risk of everything. Yeah, but what is important is here, why are those people here, the 55 to 64, or even the 35 to 44, or here, those people, why did these people die? Yeah, we have to look at those. Is it really because the virus is so super dangerous? Or is it that these, let's say 50% of these 45 to 54 are all those that are obese and diabetic? Yeah, so you have to look at more than just this to really find out what's going on. Yeah, or maybe these are all the people who live in cities, or people who live more in rural areas, or these are people who mostly have farm worker jobs where they're in crowded conditions. You know, you have to look at a lot more. So sometimes a simple graph is not telling the whole story. Always keep that in mind. Yeah, and now preventing the next pandemic. Okay, what would I suggest? And a lot of things overlap with what Dr. Benz and Dr. Higgs already said. So, but first of all, if you want to talk to people, you want to get a diverse expert panel, not just talk to the virologists and the epidemiologists and the researchers. You can talk to them, of course, but you also should include social scientists, economists, especially because we hear now that there are all these health problems because people lose their jobs. Yeah, and then you also should think about your Democrat, Senator Hurtado, right? But you want to include in your panel and your expert also Republicans. You don't want to exclude somebody. You want to include all experts. You want to bring people together, because when you come up with measures, you don't want that the other party is blocking it, right? You want to get, this is just a practical recommendation, which you're probably already doing, I don't know. But this is how to get people together, because we can only solve these things together, right? Yeah, so based on what this mix of experts comes up with, you might want to maybe make a strategic plan or multiple strategic plans with long-term goals, and then you might want to start some task forces. Yeah. Okay. Yeah, and then there are some little things. It's actually interesting that, you know, even though we didn't know what everybody was kind of presenting, you know, we haven't seen each other's presentation, we kind of overlap a lot. That's already a good sign that we are on the same page, right? So local hospitals and quality of healthcare, we already learned that this is not really great. Yeah. Here at CSUB, for example, we have a small nursing program, lots of students that actually have good grades. They cannot get into the nursing program because it's too expensive, and it's being told to the students that there are not enough internships with the local hospitals so that they can get the degree. So there is like a needle ear or the bottleneck or so. It's kind of not possible. So we have then started this new degree, human biological sciences, but the students actually wanted to become a nurse. So why is that? Why is there not more money to actually expand on this? This is like a problem and a mystery to me. I don't really understand that. And then we mentioned that before, lots of people have no health insurance. And then we have also the seasonal workers who come here for a season, maybe contract the disease, and then we never hear from them because they might die back in Mexico, Guatemala, or wherever they're from. Yeah. Then our health education. How good is our health education? You know, if you want to prevent diseases and if you want to keep our population as healthy as possible, you have to invest in a good health education, like exercise at school, you know, go swimming with the course. Yeah, healthy diet, and not just this cheap diet that you can see at lots of schools. You know, even though some schools have now school gardens, but if you really go and look at the school garden, it's like ridiculous, really. There could be so much more improvement. But then they have problems with, okay, who is kind of, who has time to kind of invest in this garden? There is no extra pay. So it's based on volunteers, and there are not that many volunteers because everybody is overworked. And then it could actually bloom so much better if we would have a little more support for that. Yeah, so health education is really, really important. Reaching all the vulnerable groups, like East Bakersfield, for example, is underserved. Yeah. And then we have to look, when we look at the population, who's living in crowded housing. So even if somebody is sent into quarantine, and they can't even do that, where should they be? Outside in the garden? Yeah, it's sometimes impossible. Yeah, and then also when you come up with measures or recommendations, you want to earn the trust of the population. You want to involve them. You want to also hear their voice, and you want to actually identify if there's any misinformation going on, fake news. You want to identify that. And you want to be clear with everything. And if you make a mistake, you admit the mistake. And you're not kind of saying everything was done right when it wasn't. You know, people are not stupid. They will then don't trust you anymore, and then you have lost. Yeah, so this is also nothing new. We already know these kind of things. Yeah, and then to spread what we want our message, we have to be present on social media. So especially the young people, they're all on social media all the time. So we have to reach the social media where the young people go. Yeah, when we want to educate them, and where maybe middle-aged people go. Yeah, elderly is always really difficult because they might not be able to do that. You know, there are some that you can't reach anymore, but then they might have supporters, their families, their friends or something. Yeah. So you have to work that the public accepts the measures. You know, like now we have these lockdowns and the people get tired of it. So many have no jobs. And at the same time, there's unemployment benefits to some of them that they don't even want to go to work. You know, there are these things that are not going right. And then I have one more slide. What are the costs? Yeah, so I mentioned that before. What are the costs of preventing the next pandemic? So this is difficult to answer because we cannot look into the future. There might be some pandemics that start and then magically disappear. You know, this actually happened with SARS coronavirus 1. It magically disappeared. It never really made it into a really significant global pandemic. And everybody said, okay, this is also with influenza. There's this vulnerable viral envelope when it's kind of drying up, when the sun is shining on it. In the summer, it disappeared. And it usually does. And with SARS-CoV-1, it did too. And that's also why Donald Trump said it magically disappears. Many people believe that, but it didn't. Yeah, it is it's more contagious, and there are other tricks that this virus has on its sleeve. And of course, at the beginning of the pandemic, we don't know that pathogen that well. Yeah, so this actually takes some time to really come up with what has to be done first, and this is going beyond our little fire pit talk or so. Yeah, but it's difficult because even Dr. Fauci was wrong at the beginning. Yeah, how much does it cost? How much money do we have? You know, and how do we want to have the bill paid? You know, now we have so much money spent. Is the next generation paying this all off? Yeah, who's profiteering from all this? And maybe the pandemic profiteers, they should actually pay a little bit. Yeah, that would be morally just, right? To ask them. So there should be social and economic justice, because if you don't have social and economic justice, you have people demonstrating against your measures. Yeah, and then I know there's the county general management plan, and that should include everything. Yeah, so you have to have your task forces ready for every topic in that management plan, that's a Central Valley management plan, and that should include improving health and, yeah, hopefully preventing the next pandemic. So this is my last slide. Thank you very much.
Thank you, Dr. Lauer. There's just a lot of great information that you provided here today, and along with Dr. Baines and Dr. Higgs. I would love the opportunity to have a round number 2 of this town hall, because I just think that the information that you all provided here today is just so valuable. And I know that I have many questions to ask, but I know that we're also running short on time, and I want to provide you with an opportunity for a closing statement. But above all, I want to thank you for participating, for the information that you provided today on preventing the next pandemic. And I also want to thank our viewers for watching and tuning in. And we hope that you continue to stay in touch with us so we can answer some of those questions that you have out there. And we'll begin with Dr. Higgs.
Well, all I have to say is thank you so much. I've read your resume, and it looks like California has the right person in the right job. Your dedication to agriculture, your support of rural communities, your passion for bringing us together today and highlighting what's been happening with the current pandemic and making us more aware of, dare I say, the inevitable next one. Thank you.
Thank you. And Dr. Baines?
I agree with Dr. Higgs. We've got a great, amazing representation. Yeah, I want to thank you again, Senator Hurtado, for putting this together. I enjoyed listening to Dr. Lauer and Dr. Higgs as well. There's, it gives me relief knowing that there's a lot of people that, are looking at this with different lenses. We've really lacked to take advantage of our ambulatory settings. If there's one message that I could send out is we need to empower and invest in our outpatient options. Hospitals should not be relied upon for primary care. They need to get back to seeing the acute care, take care of your heart attacks, your gunshot wounds, your motor vehicle accidents. They need to go back to taking care of their acute care. And we really need to empower our primary care and outpatient settings to step up and take care of, a lot of the COVID-19 treatment. And they've been doing that. We just need to support them. So that's my main message.
Thank you, Dr. Baines. Dr. Lauer.
Okay, so I'm Lars. So thank you very much for inviting. And as I said before, I learned a lot today. And maybe there's an option also for the audience to send questions to your team, Senator Hurtado, that we can include in our next meeting, that we might have also questions from the audience. That would be interesting.
Absolutely. We'll make sure that we make that happen, and I'll make sure to send all questions over to the three of you, and we'll get answers to our viewers today. So thank you so much to the three of you for joining us, and see you next time.